Welcome to Raaonline. Today's topic is Endocrinology of Obesity. So in this lecture, our aim is to help the primary care physicians and endocrinologists better manage obesity in patients undergoing bariatric surgery, as it incorporates a close association between obesity and the endocrine system. We'll cover the endocrine causes of obesity and the effect of pharmacological treatment, bariatric surgery, and non-pharmacological treatments on the endocrine system. This lecture will also cover practical steps for evaluating and managing obesity from an endocrine perspective. Obesity is excess storage of triglycerides in adipose cells. There is a difference between obesity and overweight. Obesity is excess of body fat, whereas overweight is body weight, including muscle, bone, fat, and body water in excess of some standard or ideal weight. Now, these are the sites of adipose deposits in the human body, and these are also the important sites of ectopic fat deposition. The brown fat, as we can see, is at the level of scapula and at the level of sternum. The pericardial fat, visceral fat, there's fat in the liver, the pancreas, there's deposits in the muscle, peripheral subcutaneous areas, abdominal subcutaneous areas, and the fats of the pericardial region and the visceral fat and the abdominal subcutaneous fat are the ones that are associated with metabolic disease. Obesity has become a global pandemic, with the numbers nearly tripling since 1975. Initially, it was thought to be a disease of the developed world. Now it has shown to be rapidly increasing trend even in the Indian subcontinent. The World Health Organization defines obesity and overweight as an abnormal or excessive fat accumulation that presents a risk to health. Obesity is characterized by several hormone disturbances. There can be primarily abnormalities which can contribute to the development of obesity. Alternatively, there can be secondary abnormalities which can often be reversed by weight loss. So, obesity can be primary, leading to various problems, or the various problems can lead to obesity. So, obesity can be primary or secondary. Obesity is also the symptom of many endocrine disorders like Cushing syndromes and hypercortisolism, and treating those disorders can cause weight loss. Obesity has conventionally been managed as a disease that results from an imbalance between energy intake and energy expenditure. However, it is now understood as a neurohormone behavioral disease resulting from altered hypothalamic control of hunger, satiety, and energy expenditure. Additionally, it has monogenic, a single mutated gene, syndromic, a group of genes are involved, and polygenic, common obesity with multiple genes involved components affecting the endocrine system. They are even more prominent in consanguineous populations like South Asians, and knowledge of endocrine physiology and dysfunction is therefore necessary to manage obesity. Obesity is managed by pharmacological, non-pharmacological, and surgical means. Bariatric surgery is being increasingly used in low-middle income countries like India to treat obesity. Patients who undergo bariatric surgery need pharmacological and non-pharmacological interventions like diet, medical nutrition therapy, we call it as MNT, and exercise support before bariatric surgery and after bariatric surgery. Therefore, these patients should be managed by experts who have knowledge of both bariatric surgery and endocrinologists. So, these endocrinologists may be referred as Barrow endocrinologists, having expertise in endocrine management of bariatric surgery patients. Obesity is associated with 4 major risk factors for atherosclerosis. These are hypertension, diabetes, hypercholesterolemia, and hypertriglyceridemia. Women have a greater prevalence of obesity compared to men because women have a lower metabolic rate than men. In postmenopausal women, there is loss of increase in metabolic rate that is associated with the luteal phase of cycle. The difference of obesity between men and women is even greater with increased age. Basal metabolic rate decreases with age. So, chances of obesity also increase with age. Each cell of adipose tissue can be regarded as a package of triglyceride. the most concentrated form of stored energy. In a triglyceride, there is 8 calories per gram of triglyceride compared to 1 calorie per gram of glycogen. Now, because alcohol diverts fat from oxidation to storage, body fat is directly correlated with the level of alcohol consumption. The production and availability of glycerophosphate, which is required for the re-esterification of fatty acids and their storage as triglycerides, is considered as a rate-limiting step in lipogenesis, and this process depends on the presence of glucose. So, presence of glucose is required for the adipose tissue formation. The chief metabolic products produced from fat are the circulating free fatty acids. Now, the availability of free fatty acid is controlled by adipose tissue cells. When carbohydrate is in short supply, a flood of free fatty acids can be released. So, this happens when a person is starving and his fat is getting mobilized. There is a flood of free fatty acids which depends upon the amount of adipose tissue in the body. The free fatty acids in the peripheral circulation are almost wholly derived from endogenous triglycerides that undergo rapid hydrolysis to yield free fatty acid and glycerol. The glycerol is returned to the liver for the resynthesis of glycogen, and fatty acids provide for the metabolic needs. Retrobulbar and perirenal fat is the first to mobilize in the incidence of starvation. Free fatty acid released from adipose tissue is stimulated by physical exercise, fasting, exposure to cold, nervous tension, and anxiety. The release of fatty acids by lipolysis varies from one anatomic site to another. Omental, mesenteric, and subcutaneous fat is more liable and easily mobilized fat than as compared to other sources. Now, what is Barrow endocrinology or barocrinology? Barocrinology is defined as the science of weight metabolism and obesity related disorders. It is coined as a portmanteau of Barrow, meaning weight, and endocrinology. So, barocrinology focuses upon the endocrine and metabolic domains of weight physiology and pathology. It includes in its ambit the endocrine, the metabolic, etiopathogenesis, clinical presentation, therapy, expected benefits, and possible side effects of therapy, as well as a monitoring and follow-up of obesity. Adipose tissue lipase is sensitive to stimulation by both epinephrine and norepinephrine. Now, lipase is the one that causes dissolution of fatty tissue or adipose tissue. Now, other hormones that activate lipase are ACTH, TSH, growth hormone, T4, T3, cortisol, glucagon, as well as vasopressin and human placental lactogen. Lipase enzyme activity or the fat dissolving activity is inhibited by insulin, which appears to be alone as the major physiological antagonist to an array of stimulating agents. When both glucose and insulin are abundant, transport of glucose into fat cells is high and glycerophosphate production increases to esterify fatty acids, and we develop fat pouches.